their phones or computers so that there's no background noise. Thank you. And is there a way for you, Ed, to increase your volume?
Increase my volume, yes. Wait a second. Is this better? Can you hear me better?
Oh, yeah, perfect.
Okay.
Yeah, thank you.
Okay. And what's happened with us here is that there's so much information being spread around social media, the preprints, the web, preprint servers, and wherever, that people don't know what to believe. And it seems like the world has turned to us and the New England Journal of Medicine and to Lancet to sort of filter through all that for them and publish what we think is the best and highest quality information. So we're getting lots of requests to publish. We're getting lots of requests. We're getting lots of views of our content, and it's just been overwhelming for us. Since this all started, we published more than 322 articles and other types of content on COVID alone since January. As this has evolved, there's a few problems that we've found and issues that we've taken on, and I can't go over all of them. It's just been such a huge problem. But one of the things that we did do is several weeks ago got lots and lots of reports about the PPE issue, something you're all very decided as an organization to sort of be a repository for the rest of the world to provide their ideas. So we published a couple of commentaries, one of them inviting comments about what to do about PPE shortages, which got almost 300 comments and has resulted in some publications on its own right. And in fact, there's a small group at UCLA working on a systematic review of reprocessing techniques for N95 masks, which we hope will be published soon. And it turns out that there's one of the problems with this is that a lot of, and this has been a problem with COVID in general, there's a lot of people who've now declared themselves as experts on fill in the blank, and we're not really clear why these people think that they're experts, and they're presenting themselves to us as experts that want to write about these topics. When it came to dealing with PPE, it turned out there are very few actual experts. And we've had to dig really, really deep to find people that actually know what they're talking about when it comes to PPE. Fortunately, we did do that. I published a podcast with a guy who used to run that section of the CDC, who's no longer with the CDC. He's identified a number of experts, and we're trying to put out a publication on this to sort of give direction towards the efforts of reprocessing PPE. The other things that we've worried quite a lot about is we've come across publications that we've published, articles that we've published that have had problems with them. One of them was we discovered that patients in one paper that we published have been reported in multiple other papers. We're currently trying to sort that out. I think there's other papers that we published that are probably problematic, but we're just now finding out about it. I got this long letter just a few days ago from somebody who's very upset about something published in the New England Journal of Medicine with the same phenomenon about publishing on the same groups of people in different papers, different journals, et cetera. We published, I wrote back to this person and said, that's the New England Journal of Medicine, that's not me, I can't help you with this. But we did identify this problem some time ago and published a letter of concern about it. And I think we all need to look very carefully at what's being published and whether or not there's duplication. I think the other, from a publishing perspective, the other really big problem are preprint servers. There are a number, most publications about COVID have been put on these preprint servers. Most have not, if they're on a preprint server, they haven't been peer reviewed. We have found errors in some of those papers. We have found errors in the preprint server version of the paper. Once it's been submitted to JAMA and we've gone through it, we found problems with it, so that the information presented on a preprint server is going to be different than the finished product that's in JAMA. This is, I think, one of the things that will be looked at very carefully after the COVID crisis has passed us, is what influence these servers have had on the discussion and on policy as COVID evolved. And I don't think it's going to be a good story. So here's a few examples. One is this paper published on Friday has already had the highest altmetric score of anything I've seen in COVID, and has had more than 60 or 70,000 downloads in a few days. It's a report on antibody testing in Santa Clara, California. When this came out, somebody wrote to me to tell me about concerns they had about the assay that they were using, and that there may be inaccuracies. There's nothing I can do about that, but we have a very similar paper being processed right now at JAMA, which is why they wrote to us. But the problem here is that everybody's looked at this data. It's been covered in every major newspaper, and it may very well be wrong. And so what we do with wrong information that dictates what people do in terms of a crisis is a real problem. Here's another one that is, this is the basic paper that was published by the IHME from Seattle, with their first projections of how many people would be hospitalized, how many people would die, how many people would need ventilators during the COVID crisis. As you know, all the major news outlets, all the policymakers are looking at these projections. They have all been wrong, every one of them. And the IHME has been the most wrong of all of them. So this is a huge problem, and it's something that, again, I think is going to get seriously reviewed after this is all over, and it's going to call into question all modeling in general. The third paper from a preprint server that's of great concern is this one, which is the basis for the chloroquine controversy. This French investigator published on, I think it's about 25 or 26 patients, showing efficacy of chloroquine. This, as you know now, that's the #1 issue in COVID. Everybody wants to treat everybody with chloroquine, and it all started with this paper. It's probably wrong. There's now another paper published in a preprint server that's showing another series of patients where it's wrong. There are institutions that I've heard about that have tried this and stopped it because of complications from the drugs. But it's sort of a evidence for how much influence a unpeer-reviewed preprint server paper can have on the world, and in fact contains information that's probably incorrect. I'm not going to get into the details. I want to get through this quickly because I want to leave room for discussion. But this is the IHME model, which, from anyone who knows anything about modeling of data, this is an extremely simplistic model that can't possibly be right. It doesn't account for hardly anything that one usually would want to incorporate in a model for predicting outcomes from an outbreak. Yet it's the one that's talked about the most. So one of the things that I think, if you look at our journal, and if you see as a general category, we haven't published on it, it's not that we haven't gotten the papers, it's that we just don't feel that the data is good enough to project to the public. So you will see that apart from this editorial discussing the problem with models, epidemiological models, we haven't published the results of any model, even though we've gotten hundreds of manuscripts, because we don't think any of them are correct, and we think they're misleading. So you'll find that. You'll also find, as a general category of things we haven't published, is results of drug trials, because we've gotten literally thousands of those, and every one that we've looked at is inconclusive. So we haven't published any. So it's not that like I said, we're not getting it. It's just that it's not there. Another model that's been talked about a lot is Neil Ferguson's model from Oxford. Not even put it on a preprint server, they just put it up on their website, and again has generated a lot of discussion. So what we've been talking, so a lot of you out there would probably like to publish in our journal and wondering what it is we'll do and what we won't do. We talk about this every day. We have a meeting later on today to talk about a series of papers that we're going to look at. And we've had sort of a series of policy discussions over the last 2 weeks about what we will publish and what we won't. We're not going to publish anything more on epidemiology. We're not going to publish any more about theories about COVID and how it might work. We're not going to publish case reports or case series if we can avoid it. I don't want to say that as an exclusive, because some of the papers we're talking about today are case series and there's some anxiety to publish them. But if you want to know what it is we're going to do, we published this the other day, which kind of lays out for the community at large what it is we're looking for. So what are those things? We are very interested in vaccines, public health issues such as surveillance, risk mitigation, containment, infectious disease issues such as therapeutic interventions, serologies, etc. We are interested in the financial implications to healthcare systems related to COVID, operational issues, something you're dealing with. We had a call on Monday in general surgery about this, that what are we going to do with all those thousands of patients that haven't gotten care during the COVID crisis? That's going to be a logistic nightmare as you are living and talking about at UCLA. And we're very interested in publishing on that to help guide other healthcare organizations who don't really know what to do as others, organizations like UCLA solves those problems. And then certainly about preparedness for the future, what went wrong this time. I think one of the biggest areas of discussion that will follow the COVID crisis is why did we fall so flat on testing? Where was the CDC in all this? They seem to have disappeared. We have lots and lots of questions that need to be answered. We are very interested in randomized clinical trials on drug treatments, and I emphasize randomized. We have gotten hundreds of case series with hundreds of patients, haven't published any of them because they are not definitive. So we would want to see well-controlled clinical trials that have control groups. Another thing that we talk about a lot at the journal has been the observation that Black patients do extremely poorly with COVID. We don't know what this is all about. We don't know if it has anything to do with socioeconomics. We don't know if it's just biology or genetics, but clearly Blacks do very poorly with this disease. And that's something that is a high priority for us to try to understand. And also, some of our editors are very interested in the role of ACE inhibitors and ARBs. As you know, the COVID virus binds to the ACE receptor, and these drugs either make the infection worse or make it better based on possible promotion or interference with binding to the receptor. So we don't really know. There still isn't a lot of good data out there about that, but that's something that is very important. Again, because the observation mostly from Italy, that patients with hypertension do very poorly with this disease. There's some kind of interaction between hypertension and COVID, and it might be these drugs. So, this is about the 5th version of this talk that I prepared in the last few days. I actually had a completely different talk planned and changed it literally this morning. And as I sent it around to a few people, I got some questions. So I thought I'd answer those questions. One of them, did we publish anything on drugs and specifically remdesivir? So I looked through the rejected manuscripts. There are, since January, nearly 6,000 rejected manuscripts at JAMA alone. And that's all content, but probably a half to 2/3 of that are COVID-related papers. Only 2 of them were on remdesivir, so we haven't really seen a whole lot on that drug. One of the questions was, why are we publishing everything as short 2-page articles like research letters and viewpoints and whatever, and not full research articles? There's several reasons for that. One, it's much easier to put data together in a 2-page, either 600-word research letter or 1,400-word viewpoint than a 3,500-word article. Those take, every article that I process takes a minimum of 3 complete days of my life to get to publication. And it's just very labor intensive for all of us at JAMA to do that. So, but these shorter articles are quicker to turn around. So we're trying to get out information as soon as possible. We're publishing articles within days to weeks of receiving them, and to put them out as short articles is easier. The other is we're sure that a lot of what we're publishing will prove to be incorrect. We're just trying to get good, high quality information out there for people to chew on, but we recognize that down the road, some of that might not be right. We don't want to commit. So it's easier just to break these observations that are sent to us into little pieces, publish a piece of it, hopefully it's right. And if it's not right, it's not a tragedy. And so, so we'd like to sort of parse it out into small pieces. And lastly, there's a strategic decision about how articles influence impact factor. There's actually not all articles count the same, and shorter articles count less than longer articles. So to preserve our impact factor, we'd rather put out shorter articles. I don't want to get into too many details about that, but that is something we do. We do think about impact factor as you do. You pretty much want to publish with us because we have a high impact factor. And did we make any mistakes? And have we seen problems with what we've published? Absolutely, we have. We've already noticed, as I pointed out before, and we published an editorial concern about duplicate patients being reported in duplicate publications. That's in the right-hand corner there. But also at JAMA, this is an issue that we spent a lot of time talking about a year ago, about what do we do about errors and retractions? Is it okay? Is it a disaster that somebody made a mistake and tell us about it, want to change their paper? Do we have to retract it? What should the process be? This was a subject of enormously lengthy conversations over the period of months. And we published this little editorial, editor's note, that we have a policy now at JAMA that we'll retract and replace. We think people do make mistakes. We think it's better to acknowledge mistakes than to try to hide them. So as papers come up that have problems and we find out about them, we would rather fix them and republish them rather than just take them off altogether. So we do have that policy. Other journals do that to some degree. Others won't do it at all. But that's our policy. One question was, what's the safe way to try to sort through the literature? Should the world rely on us and rely on New England and Lancet to filter for them? That's a question that could generate a lot of hubris for me because of what I do. My answer obviously would be, yeah, you should rely on us and don't listen to anyone else. But that might be a little bit biased. But I do know what we do. I do know what we see. It's very frustrating for me to hear. I sit in various conference calls. I hear people talk from all over the world about things. And I hear them cite articles that we have rejected. And they cite them as authoritative publications. I know why we rejected them. I know why they're not definitive. We can't say anything because we won't discuss papers that have been processed by JAMA and not published. But there's a lot of bad stuff out there. There's a lot of bad literature out there, and it's hard for people to really sort through it unless they know the details. And we have access to details that most people don't when we're processing these things. So I think the big three, New England, Lancet, and us, they have big staffs. They have the ability to sort through these things. So I think that at least we hope we're being more credible than most other people. Have we published much on surgery and anesthesia? Not yet, but there are things coming. Stay tuned. I want to point out a few things that have come up in the last few days that are important and that kind of launches into what I really want to talk about, which I'll get to in a second. The NIH just released guidelines, I think yesterday or the day before, with great fanfare. I had 3 requests to republish them in JAMA just yesterday alone. These guidelines basically talk about medications and treatments for COVID, and they basically say, no, 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 no. Don't use this drug. Don't use that. This doesn't work. Don't use steroids. Don't use chloroquine, etc. That's all it says. What not to do. So I elected not to publish this because of that. But if you look at the level of evidence, it's all based on expert opinion. And what that tells you is that anyone who's providing recommendations or anyone that's giving sage advice is really speaking really off the top of their head. There is no good evidence for anything that we're doing with COVID. And I've seen pretty much all of it. And it's just a fact that there's just too much going on and there's not good evidence. So I want to talk about elective surgery because that's something you all are very concerned about, and the resumption of elective surgery. So again, I think within the last week, the American College of Surgeons and other organizations got together and provided guidance for resumption of elective surgery. And this is from their document. And you can see that they recommend not resuming elective surgery until 14 days after COVID, the incidence of COVID declines. I don't agree with that. And there's no evidence to support that statement. And to highlight that, they cite 4 citations on that particular statement. Those 4 citations are a report from the American Enterprise Institute by people who don't really have any particular expertise in COVID or surgery, an article from the Wall Street Journal, an article about the IHME projection model, which we all know is incorrect and has never produced an accurate prediction, and then another prediction model. So that's the basis of their recommendation, which is they don't have any better basis than anyone else for making that recommendation. Similarly, they recommend COVID testing at facilities, which is something I know that you all are very concerned about at UCLA. I'm going to get to that in a second, but that's not going to help much either. So since everybody's talking off the top of their head, I'll talk off the top of my head based on my observations as a JAMA editor who's been kind of at the center of a lot of information, because pretty much everything that's said about COVID comes our way. So if you're thinking about patients coming to the operating room in this time when COVID's in the community, we're never going to know which patients you have COVID or not. There's no testing that's going to tell you that. And so you just have to assume that everyone that you're treating has COVID, just like we do for bloodborne disease. We sort of assume that every patient that we touch has the potential for hepatitis or AIDS or whatever, and that's why we use universal precautions. So I think we should adopt a strategy of universal respiratory precautions for the operating room and just assume everybody has it. Now, why do I say this? One, if you're relying on PCR testing to identify COVID, forget it. It's not that accurate. We've published a paper that showed that the clinical sensitivity of the test for craniopharyngeal swabs is as low as 30%. That's backed up by an observation that I've seen, it's not yet published, that about half of all patients who were proven to have COVID after surgery had no symptoms going into surgery and or had negative testing before surgery. So we just don't know who's got the disease. It's better just to assume everybody's got it. There's an enormous amount of discussion about antibody tests, and everybody sees this as a potential solution for getting us back to normal. It's not. We have something coming from the CDC in the next few days. I shared pieces of it with Joe that basically talk about what this testing is going to do or not do. The antibody tests have unknown sensitivity and specificity. There are literally hundreds of antibody tests out there developed by various organizations. They're not standardized. It's not known how good any one of these tests are. And most importantly, even if you find an elevation of IgG or IgM, you don't know if the patient has blocking antibodies and has COVID immunity, and that's not going to be known for months to years. So we don't really know what the result of this testing means, either in terms of whether you've had the disease or not, or if you're protected from getting it just because you have antibodies. So I don't think testing is going to help us. Again, tells me it's better for us to adopt a strategy of assuming everybody's got it and take precautions in the OR. We do know that COVID can be found all over the place. We published this report that showed that if you look at various body fluids, that a fair number of patients have COVID virus. They have the SARS-CoV-2 virus in their intestinal contents. There was even a report of blood levels, COVID SARS-CoV being detected in the blood of patients. So it could be almost anywhere in the body, even though it's mostly concentrated in the respiratory tract. We also published this, which actually resulted in a change in the CDC guidelines. But when someone coughs or sneezes, they develop a respiratory cloud. It's not droplets that just go flying all over the place. It's actually a cloud. And as you know, clouds float through the atmosphere. And these clouds can go as far as 20 feet from a patient. And because it's a cloud, the viruses are protected by a moist environment, and they can just go very, very great distances. So we also have to assume that if there's been any kind of dispersion from the respiratory tract, say during intubation, or a patient bucking on the vent and around the ventilator tube, that there are streams of respiratory content that have these clouds that are probably floating all through the operating room. And so that no space is safe. To back that up, we also published a paper showing that if you look at the room and PPE for where patients are who have COVID, you'll find the virus all over the place, including the air vents, which also supports the cloud theory that this virus just sort of wafts through the atmosphere and can go all over the room. Also, we were, I think, the first to publish asymptomatic transmission. So we did show that people can transmit to one another without any symptoms at all. And that if you talk to the people in Seattle, that clearly was happening in Seattle. They have good evidence for that. So again, you don't know who's got it. You just have to assume everybody's got it. So there's no good data for anything anybody's talking about with COVID. So I think we just have to use our gestalt. And my gestalt from looking at a lot of this stuff is that we should assume that all patients in the operating room are COVID positive. We should use universal respiratory precautions using N95 masks, just as we use universal precautions against bloodborne diseases. PPE can be reprocessed. There's a good body of literature on that. Max Schum and Joe Hadaya, are doing a systematic review with Melinda on that very topic. There's good evidence that you can reprocess this stuff. So I think we can conserve it. So I don't think we should worry about that. And the OR staff are brave. I did one case during the COVID era until I was kicked out by Dr. Chen, who told me I'm too old to be in the OR because I'll get sick and die if I get this thing. But I was impressed by how people are generally concerned, but they're doing their job, and they're under very difficult circumstances. We need to protect them, and I think everybody working in the OR deserves to have what we call at UCLA level 2 PPE. Again, assuming there should be universal precautions. So, who are our heroes? There are people who have done remarkable things through this COVID crisis. This we published a few days ago. It highlights Fauci and the Chinese physician who tried to tell the world about COVID till he got picked up by the authorities in China, the Italian ICU physician who did so much to teach us about how to manage sick COVID patients, and then the rest of the healthcare world. But based on my limited observations clinically, these who I think are our heroes. They're the residents. The residents, I'm just absolutely gobsmacked by how professional they are. They're the ones that are in the line of fire. They're the ones that are taking risks. And my hat goes off to them, as I think they're doing a remarkable job. They've been extremely professional. And I think we really owe a debt of gratitude to the residents for all that they do for us. I'd also, as preparing this talk, I found this. I'd like to thank Marty Pops, who there's probably only a few people on this call who even know who he was. But Marty Pops was the Dean for Student Affairs when I was accepted to the UCLA School of Medicine in 1983. And this letter changed my life. I don't think that they ever dreamed that I would grow up to be a JAMA editor, but I did. And I got here because of UCLA. And I owe a lot to everybody who was involved in my training and people I worked with for all the years that I was here. And it was just, it's been a remarkable 37-year relationship with the institution. So that's all I have to say. If you want to publish in JAMA, then you can certainly contact me. I'm on your faculty. I'm here to help you get into the journal. And so I have my address in Chicago, my address in LA, and I'd be more than happy to talk to people about what it takes to get published in JAMA, and more than happy to discuss any of what I just presented and answer any questions. Thank you.
Hi, Ed, it's Richard Shaman. I have a question. Can you hear me?
Yes, I can.
So obviously, this is a great talk and helps put things in a lot of perspective, particularly for what we know and what we don't know. But how would you tell us we can speak as we open up our surgical volume again to the patient's concerns about coming to the hospital, puts them at risk, particularly for surgery that needs to be done, but not totally elective. Obviously, there's always a risk balance and benefit analysis that goes into every decision. But, you know, we give a lot of public information on the UCLA website. And I think one of the things as we open back up is to give realistic and real information to patients so that they can not have the fear that coming in for their surgery will put them at risk of walking out or developing contact with the virus and getting sick from that.
So I think what I would say is that the risk of getting COVID in the hospital for a patient is probably not much greater than getting it in the community. And the reason I say that is that most hospitals have cohorted patients to specific areas of the hospital. They've done a very good job of isolating them to one place. So the likelihood that it's going to leak out of that area, given good infection control practices that are in place at pretty much every hospital, I don't think the likelihood is that great that it's going to leak out to non-COVID parts of the hospital. Then COVID has been in our community probably since the fall. And there was a time, despite all of our isolation and quarantines, there were 20,000 people coming to California, 7,000 or 8,000 per day coming in from China through California when all this started before travel was stopped. So there's COVID all over the place. It's been around for a long time. I don't think it's any more likely to get it in a non-COVID part of the hospital than it is from getting it in the community. That's my opinion. Just again, based on a lot of epi that I've seen, but patients may or may not feel comfortable with that, but that's what I believe.
Ed, thank you so much for giving this talk. Extremely informative. So if we cannot rely on the COVID detection test and we cannot rely on the antibody test, then what should we just do?
I think, again, that's why I'm advocating universal respiratory precautions and just assume everybody's got it. And that, especially for the OR environment where it's a high risk of being exposed to bodily fluids and vapors and whatnot, gases, I think if you just take those precautions, just like we wear gloves and eye protection when you're exposed to a patient's blood, I think that's what we need to do. Probably for the next few months, while the incidence is, or while there's still a prevalence of COVID in the community, we should probably have those same kinds of protections in the clinic environment as well. So again, it's my guess. I don't think anybody has any good information, but I do know from what I've read over the last few days, I got 4 systematic reviews of testing 2 days ago. So I've read a lot about testing in the last couple of days. And from what I've read and what I've heard from the CDC is that these tests are not that reliable. They're not going to be reliable for a time. So I think we just have to, and we can't put off patients forever. That there's going to be a downside of, patients with bad gallbladders and cancers and hernias. They're going to get into trouble if you leave them out there long enough waiting for this to settle down. And we're going to cause other problems by not dealing with them now because of these concerns about COVID.
It's quite concerning. It seems that it's not going to go away until we all get it at some point.
No, it's probably going to be around for quite a long time.
Ed, this is Cliff. Can you hear me okay?
Oh yeah, like a pro.
Oh, great. Hey, how are you doing? So from the college standpoint, should I write, or should we write, the college write a policy or a recommendation that regardless of the test, everyone should wear 95s in the OR? Surgeons. I mean, everyone in the OR, but I'm talking about surgeons here. Should we do that?
I think so. And I actually am thinking of writing something like that for JAMA. I really came up with this in preparation for this talk, just going through all this data and this is the first time since January I've had a chance to sit back and reflect on what I've seen and what I've heard over the last few months. And also I had the one experience of being in the OR myself, and I was impressed by how professional everybody was and how concerned everybody was. But I think to reassure the workforce, even if it's for that alone, just do it. Just give them all N95s. Let people feel as safe as they can. Adopt this policy, and you'll probably be okay. I don't think it'll hurt to not do it. I think it will do more harm not to do it, because I think it'll send a message to the OR staff that we're willing to sacrifice them. Whereas they're quite willing to take a lot of risk to take care of patients. So I think I can't remember where I saw it, somebody said it's like you wouldn't send a fireman into a burning building without the proper equipment. And I think that's what we need to do for everybody in the operating room. Just give them level 2 PPE until this thing has gone away. And again, there's no evidence to say you should or shouldn't do this. So in the absence of evidence, I think you would do the best you can to make people feel better about what they're doing.
And then what we hear is that, all right, our hospital doesn't have enough. Should we not do surgery? And then that's how people got to the testing, recognizing that the rapid tests are not, there's too much variability in the rapid test, but the regular test is much better. But it's always going to have a problem with the swabbing.
Yeah.
Any test. So do you think that is something that's going to be a problem with every single test, and we shouldn't rely on that?
Yeah, because like the swabbing, at least one paper we published, I couldn't find it for this presentation, showed a clinical, the test itself is great. I mean, it's like 99% from a molecular perspective, sensitive and specific, but the clinical sensitivity of swabs is as low as 30%, because the virus may not be in the craniopharyngeal area. It may be down deep in the lungs, so you may just miss it. It's very, very good from bronchoalveolar lavage specimens and bronch specimens, but swabs aren't that good. So there's a lot of uncertainty with that testing. I don't think you can feel secure about it. I think
And then
testing is giving people a false sense of security.
And one last thing is that the test, whether it's has good test characteristics versus not, in a low versus a high prevalence kind of population or subpopulation, what is your comment on that?
I can't say too much because we have a paper about this in process. I can actually send it to you to review, I guess. But
Oh my God! Wait.
suffice it to say that testing isn't that reliable for surgical patients. This is for surgical patients.
But apparently, in looking at this, there's a lot of tests that we use that are not so reliable, but it's in a low prevalence subpopulation that at least public health experts have accepted that it's okay. ID experts have accepted it's okay. A lot of times are flu things and all these other things. And there's like, well, this is not really different in low prevalence population, which is like the asymptomatic person who's been isolated and whatnot.
I think where this is going to go is like what happened with AIDS. So as you might remember from the 80s and the 90s, there was a time in the early 90s when surgeons wanted everybody tested for AIDS. And I had troubles at the VA when I was there with surgeons that wouldn't operate on people with AIDS because they didn't really know much about it. And then universal precautions just sort of got adopted because testing is kind of hit or miss. And now we just treat every patient like they may have a bloodborne illness. I think that's what we need to do here. I can talk more offline about some of the details of why I think that. Some of the stuff I can't talk about because it involves non-published literature that I've looked at.
Okay.
But that's just what I, and I'll be happy to send you this thing for review.
So there are a few questions regarding the use of N95 masks in the OR. Dr. Denomi is asking, do we have enough for everyone if we are going to use them for all the cases? And then there are a couple of questions about how safe it is to re-sterilize and reuse them.
Mm-hmm. So I can't speak to how much you have. My understanding is you have quite a lot, but what a lot of places are doing is you have your N95, you have your personal supply of N95 masks. And as long as you keep your N95 mask under a regular surgical mask, it's probably not going to get wet or dirty. And as long as it's not wet or dirty, it can be sterilized very easily, either using UV light or hydrogen peroxide. So Max Schum has reviewed this. He's now the expert on this. But these are easily reprocessed. The CDC did studies years ago, knowing that this is going to be a problem someday. There's very good literature out there showing that this can be done. So if you have your personal supply of N95s and you can, alternate masks, every day you put on a different mask and send the other one to be reprocessed, there should be enough to support this kind of effort.
There's another question which you may or may not have read about beyond the hospitals and the OR. When do you think that local business should restart, schools should reopen?
That's above my pay grade. I have my opinions. I probably better not express those opinions. So I that's not something I can really get into.
This is Jessica O'Connell. Can you guys hear me?
Yes, Jess.
Thanks, Dr. Livingston, so much for that. So what about aerosol generating procedures? Do you think that N95s are good enough, or should we be wearing PAPRs for all the head and neck cases, the intubations, the bronchs? Thank you.
Well, the PAPRs are better, but N95s are probably, as long as it's working well, it's probably enough. The good thing about the PAPRs is they're easily reused. They just have to clean them off. So it really depends on what you have, but N95s, as long as they fit right, and if you put a mask to protect your face over that, you're probably okay.
Are there any positive, optimistic news?
Optimistic?
Yes, something happy.
This will go away. So one of the talk that I threw out to talk about the OR stuff was about our kind of evolution of our thinking about COVID. And we're fortunate in that Tony Fauci has become sort of the center of the universe on this, but Tony is a good friend of JAMA. We all know him really well. And he's been giving us interviews almost every week since January. And the very first publication we had in JAMA on COVID was written by him back in January. And so he's about the only person that I listen to because he's really very rational. And I actually kind of blew off in a very public way, blew off the seriousness of COVID. I was so wrong about that. I published a patient or a infographic showing that, you know, we really should be worrying about the flu and not COVID. And that came from a guy I was working with at the CDC. 500,000 people looked at that, and it was wrong. And a couple of weeks after I did that, Fauci, in one of his interviews, I think it's his third interview with us, said, "This is bad. This is the worst thing I've ever seen." And Fauci was in the middle of AIDS, H1N1, you name the epidemic, he was a central figure. And he said at that time, "This is the worst." And then Carlos Del Rio, who's another expert in this topic, a few days later, in another interview that we did, said, "This is why it's a problem. It's a brand new virus. There is no immunity. There is no treatment. It's going to rip through the communities, and it's going to kill people because we don't have immunity or treatment. It's not like the flu where you do have immunity and you do have treatments." Those two things really shook me up. So I've been listening to those two. And so what Fauci said the last time we talked to him, or time ago, he said, "We really can't reopen or get back to our lives until the death rate starts to show that it's on the decline. The case numbers are unreliable because testing is unreliable, its availability is unreliable. The only thing that we know pretty much for sure, even though case definitions kind of vary, is who's dying from the disease. And when those rates start coming down, then we can probably all start breathing more normally." And if you look at Seattle, those rates have already come way down. So Seattle's probably past their bad times. They're starting to come down in LA. The last several days, things have been that number's been going down. So if you look at the fatality rates in most of the country, they've been on the decline. So that I think is a there should be a sense of optimism that maybe this is going to get better, maybe this is going to go away. So, but that's the number that I would look at is the death rate.
Thank you, Ed. Do we have any more questions from the audience?
I also want to say one last thing. Because of where I'm at in JAMA, I've got information coming in from all over the world and talk to people all the time. And I've been very impressed by how UCLA has conducted itself in this. Not all institutions have been this good. And they've been very professional. Everything that I hear, that like the latest thinking, they seem to have heard the same thing and are developing policies as a result of it. They're very well resourced. There are things that people are worried about in other institutions that have not come up at UCLA. So I think all of us that have the privilege to work here have a lot to be grateful for. It's a very well-run institution, and whatever complaints people may have, you're in way better shape than in a lot of other places. So I certainly am glad that I'm back. I thank Joe and Dr. Bustill for bringing me back, but it's a great place. You're fortunate to be there.
Ed, this is Wes Moore. Can you hear me?
Yes, I can.
Just a quick question with regard to when you think it will be possible for us to have gatherings or real meetings other than Zoom. I have a personal interest in this, in that we are scheduled to have our annual vascular review course the end of August. The question is, should we be thinking about canceling, postponing, or what's your thoughts on this?
So that's been kind of kicked up to the political realm, and there's a disconnect between what the politicians are saying and what the medical community wants. That's really not quite clear. From my personal opinion, and I say that having been very publicly wrong in the past about this, is that by August things will probably be a lot better. But it could be that this disease just sort of churns through the environment for months to come. It could behave like SARS version 1, which just suddenly disappeared one day. Just in the middle of vaccine development, it just went away. It's really, really hard to say, but I think by August, I'm hoping that things will be back to normal. That's not going to be anything that You or I get to determine. Political leaders will decide what we can and can't do, and we'll just have to do what they tell us to do.
I have a question. What are your thoughts about the healthcare worker infection at UCLA? This is a topic that kind of was hidden until the LA Times article kind of put it on the map. You know, there's a dashboard that is being used to track these patients, but we don't really have access to it. UCLA is saying that they've tested 8,000 or 9,000 people and 600 have come back positive, and then there's 200 healthcare workers that are positive. I mean, do you feel secure that this is a situation that's under control? And if so, what have you seen to make you feel that way?
I don't, if you break down those percentages, given the numbers that are now being kicked around from community-based testing, the proportion of healthcare workers that are positive is probably not much more than the community at large, which suggests that they could have just as easily got it in the community as they did in the hospital. So I don't think you can I don't think you can tell that they got it in the hospital because it's so prevalent in the community. So I just don't think you can say that very securely one way or the other.
But are you concerned that they could potentially transmit it to patients and not know that they even have illness? I guess is the question.
Yeah, but that could be anywhere in the community, which is why I sort of advocate for this universal PPE, this universal respiratory precautions approach. That anybody could give it to anybody, whether you're in a hospital or not. So, and it's clearly transmitted in the asymptomatic stages. So I don't see that where the hospitals, it's so prevalent in the community. It's not like we take all the cases and stick them in the hospital. In fact, I just wrote a note this morning. We have a bunch of papers we're going to talk about this afternoon, and one of them is about stay-at-home orders and how they might influence the disease spread. But if you look at the data, you know, one of the things you've all noticed, right? Nobody's coming to the ER. The incidence of patients coming to the ER for MIs, for strokes, for things that should not be at all affected by this have plummeted all across the country. People just aren't seeking care. They're staying at home. So I just don't know that we know that, again, this is because it's so prevalent in the community. I don't know that you can say that it's specifically concentrated in hospitals because people are staying at home and they're staying in the community and not coming to hospitals who probably have it.
If I may ask you one more question, you know, that bulletin that's sent out every day, if I recall it correctly, the number of COVID patients in the system has been very stable at about 40, and ICU patients has been less than 20.
Yep.
Can we justify shutting down an entire hospital and continuing to do that based on those numbers, even if they're not declining?
Yeah, I think because of the potential for a surge, that was a wise strategy to empty out the hospital, preserve all your resources, because there were surges in places. And if you talk to people who've been in the middle of surges, and I have, they just got clobbered, absolutely clobbered. It's interesting to talk to these people because every one of them talks like they've just been in a foxhole during World War I. They've all got like their bells rung by the experience. It's really bad. So I think holding back in anticipation of a potential surge was a good thing. It now looks like that surge isn't going to happen. I've made the same observation you have. UCLA's had remarkably steady numbers. That's not been the case at Cedars. They got clobbered. They got a lot of patients. So just down the street, they had a very different experience. But the death rate in LA is falling, and it's falling rather rapidly. So I think given, you know, the kind of thing Fauci says, if the death rate continues to decline, then I think we can start kind of coming out of our holes and rethinking about reestablishing routine care.
Dr. Livingston, there is a question related to that. So if we rely on the number of deaths, don't you think that it will go up as soon as the social distancing is lifted?
My personal opinion, probably not, because I think this disease has been in our community probably since November, December. It's not quite clear how long. And I think a lot of people have been exposed to it. So I'm not so sure that social distancing has been as effective as it has been. Again, this is a whole topic of discussion, but before social distancing became in vogue, that entire concept was considered to be ineffective because it had been tried in prior epidemics and didn't work. So until I guess the political leaders all decided, and some of the clinical leaders, that this needed to be done. Just, back in January, people were saying this has been tried and it doesn't work. All of a sudden it's been done and everybody's saying it's working. So I'm not so sure it's that effective. That's my opinion. There's probably a lot of people who disagree with me, but again, I've been in the center of these discussions since January. And it's interesting how people's attitudes and statements have changed with time. So if I had to bet, and again, I've bet in public and been wrong in the past, but if I had to bet, I'd say that if we relax on social distancing, not much is going to change.
A couple more things. I mean, there are a ton of questions. I don't think I'm going to get to all of them, but do we need negative pressure rooms in the operating room? Do you think that would make a difference?
That's not practical. And I just saw a paper about something else about negative pressure rooms that show they don't work. Unrelated to COVID, it had to do with infection in orthopedics, some huge study from the UK. We didn't publish it, but I'm not sure that they're that effective. I wouldn't feel that, I wouldn't want to rely on it, because those bugs could be passing by you as they're going into the negative pressure filters. So I would feel very, very safe if I had an N95 mask on underneath my regular mask.
And should we have those in the perioperative care areas as well, pre-op and post-op, and in the wards?
Which, the laminar flow?
No, the N95s.
I think you should wear the N95s everywhere, yeah, as much as you can.
Why do you think California has much lower death rate than New York City?
Nobody knows. It's not just California. There's almost no COVID in the Midwest. Very, very little in Texas. Very, very little in Southern California, but there was a hot spot in San Jose. Seattle got clobbered. New York got really clobbered. Boston's getting clobbered. We don't know. Nobody really knows why things happen that happen. We don't know why Milan in Italy got just creamed. But the rest of Italy, it wasn't that bad. It was bad, but Lombardy just got clobbered. So why these certain hotspots happen, nobody really understands.
Okay, so I think we are going to stop here. Thank you so much for taking the time to speak to us.
Sure.
It's very, very important.
Thanks, Ed. Thank you very much.
Sure.
So next, so our anesthesia colleagues, you're welcome to stay on the line. Dr. Still will say a few things, and then Dr. Hines will talk about the plans for ramping up the ORs as early as next week, maybe. Dr. B, are you on the line?
I'm on the line. Can you hear me?
Yes.
Yes. Ed, first of all, I really want to thank you for a very, very comprehensive and very informative discussion. It was really, really great. Thank you so much. So good morning, everyone. And I truly hope that you all are doing as well as can be expected during this unique and extremely difficult time that we are all going through with the coronavirus epidemic. Again, I'd like to thank Dr. Livingston for his thoughtful and comprehensive analysis of the COVID epidemic, which has certainly affected our program, but we're very fortunate it hasn't affected our programs as much as it's affected other programs around. And I certainly concur with your remarks, Ed, that our residents are certainly so important during this serious epidemic, and I want to truly thank all of them for their very selfless contributions. Thanks, everyone. We couldn't be getting through this without your exceptional help in all of this. I only hope that the preliminary data that is being reported as favorable is accurate, and I think Ed Livingston has given us some other insights into that, and that we are getting this under control with selective isolation, the use of N95s, and extensive testing. I think we're very fortunate in Los Angeles and at UCLA that this thing has not gone crazy. Again, I wish to thank all of our faculty, house staff, and our medical school and hospital leadership for their dedication and commitment, which is helping us weather this incredible crisis that we are all facing. Incredible, it certainly is. I think as I discussed with you in our last 3 meetings, I would like to update you on how this pandemic has spread and give you some data. Which you probably already know. Worldwide, there have been over 2.5 million cases with 170,000 deaths. In the U.S., just over 825,000 cases with close to 45,000 deaths. And in Los Angeles, which we're really kind of low considering our population, there have been over 13,000 cases with over 650 deaths. If you have not seen the report, which came out on Monday evening from Drs. Rob Cherry and Karen Grimley, please check your email since this contains important information. In summary, as they indicated, we have been extremely diligent in trying to combat this epidemic, as all major health centers have done. At UCLA, testing has been done in over 8,400 patients since March 9th. And of those, 674 tested positive with a total of 131 admissions. And as Dr. Livingston said, I mean, this testing is basically nasopharyngeal swabs, so we don't know really what the accuracy is of that. Currently, we have over 40 plus patients at UCLA hospitalized, and with, as of last night, there were 12 in the ICU, and there are close to 200 healthcare workers at UCLA who have now tested positive for the coronavirus. Currently, there has been established a clinical trial which will hopefully soon go into effect to try to determine what the incidence and prevalence of COVID-19 is among asymptomatic and minimally symptomatic healthcare workers at UCLA. Hopefully, this will be successful in early identification of patients who are capable of transmitting the virus while being asymptomatic. Additionally, as you may be aware, UCLA has a trial of a drug, remdesivir, originally developed for Ebola to treat COVID-19 patients. This trial was started and there is no significant data yet. Now that we are planning to ramp up our surgical case volume, which we have to do extremely cautiously, we have to be very careful in identifying which patients should truly be considered for surgery in this crisis. Criteria which we will need to follow are: number one, patients must have testing 1 to 2 days prior to surgery at a UCLA testing site. Number two, patients should have no close contact with a COVID positive patient 14 days prior to surgery, and it's difficult to determine how that is exactly going to be monitored. Number three, a patient should be free of any influenza symptoms on the day of the operation, and this means no headaches, no coughs, no upper respiratory symptoms, etc. These policies are available for review at the UCLA Health COVID-19 website, and I encourage all of you, please take a look at this. Finally, I'd like to share with you some data that illustrates how this COVID epidemic has affected surgical volume over the last month, from March 13th through April 12th, 2000. During this time, we have had a total of over 900 cancellations among all of our divisions, and these included only patients who were canceled specifically because of the COVID epidemic, either due to the decision of the patient or to the primary surgeon. However, we anticipate that close to 80% of the canceled cases will reschedule as soon as is safe at UCLA, but we must be aware that we are still in the position to lose cases due to rising unemployment and loss of health care coverage of these patients. Despite this, there are opportunities for growth with increase in tertiary and quaternary cases, which will be most likely be significantly diminished in the private surgical community. These cases are really not being done except in tertiary quaternary centers such as our own. Obviously, this has been an unimaginable time for all of us, and we must stay optimistic and continue with a strong commitment to our patients, our colleagues, our trainees, and most of all, the priority has to be that we have to be safe and our patients have to be safe. So the fact that we really want to ramp up things has to be done with extreme caution. So I want to thank all of you. And again, Ed, I want to thank you very much for a very, very insightful, informative lecture that you have given us today. Thank you so much.
Thank you, Dr. Busutil. Does anyone on the call have questions for Dr. Busutil? Thank you again. So
Thank you.
next, we will move to Dr. Hines, who will give us an update about the perioperative plans.
Thanks, Ariti. We'll give everybody a quick snapshot of what's been going on in the ORs and what the at least preliminary discussions are about the volume that has been postponed that Dr. Busutil described. So we're in week 6. We started this process of ramping down March 16th. Since that time, we've done considerably less elective volume. But of course, there's add-on work that has to be done, urgent cases, patients that are in-house or have urgent or emergent needs. So in the Ronald Reagan main OR, if we look back over the last 6 weeks, the volume has been 50% of usual volume. We did 680 cases. And in the Santa Monica main OR, 39%. We did just over 300 cases in the main OR there. So everybody knows the surgery center in Santa Monica was closed, and all that work was consolidated into the 200 medical building. And that combined volume is about 27% of average volume. So if you look across all the peri-procedural areas, including some of the community surgery centers, the volume is about 26% of what we would have normally done during that 6-week period. And if you include all of the departments of surgery, the 7 departments of surgery, there have been about 2,800 operations that have been postponed over that 6-week period. And if you model that out as to how we might bring that volume back in, it's going to take a while to do that, some months to get that volume back in, even if we started today. So that everybody understands that we're not going to be turning on a light switch and then all of a sudden we'll work through that volume in a few weeks' time. The idea of bringing us more of an elective schedule back online really has to do with the fact that the seems to be a pretty stable census in-house. Actual number of new patients admitted or diagnosed admitted has dropped over that period of time, but our numbers have gone up because patients continue to be in the hospital and getting care. And a lot of the things that Dr. Livingston outlined, that it may be safe to start getting back to work to take care of the issues that patients need to have addressed and who, with time, will be worse off if we don't. So there's a working group coming together actually later this morning to talk about the details, but I'll give you a few preliminary ideas of what has been discussed. So we're going to go in 3 phases. So case list was sent to all the department chairs, and they have sent back all those materials yesterday, categorizing the patients into 3 buckets. So those patients that need to be done within the next 3 weeks, those that need to be done in the next 3 to 6 weeks, and then beyond. And the OR scheduling group is going to be using that information to begin to kind of prioritize and schedule cases in. In this phase 1 period, we're going to definitely obviously evaluate the necessity of the case based on clinical needs, and we're going to rely upon the chairs to help us to prioritize those buckets. We're obviously going to be providing screening for all patients, and UCLA is now accepting tests from a few additional institutions like Kaiser. Some more details about that will be coming out. And then, of course, screening of staff who are symptomatic. In this first phase, we're going to make sure that we have sufficient PPE resources, that the workforce is healthy, that we have the facilities and the supplies, and that we're not jeopardizing COVID testing capacity in the event of a surge. when we bring patients in the hospital, we're going to continue to be sure that we're taking social distancing measures and cohorting patients like was described earlier into non-COVID areas. So that'll be the first phase. Once that is completed, then we'll move into the second phase. The second phase will really be based on where we are again. We're going to reassess the current recommendations from LA County, look at the UCLA surge plan, again, make sure we have enough PPE, staffing's available. And then secondly, to make sure that we have enough ICU beds and vent availability, because some of these patients will be coming in, cardiac patients or different more intensive operations, could potentially be taking up beds. And as you know, the census in Reagan and in Santa Monica runs very high, and we don't want to get back to that number of 100% plus in census, so that we can accommodate a surge if it needs to happen. So bringing volume back on will not be that we're going to get back to where we were before March 16th. Still, the census of both facilities will run lower than historical averages, so that we can accommodate a surge if and when it comes. And there's been a discussion that this may happen again in the fall. And so we're going to be kind of in a constant state of being prepared for a surge and walking, balancing all the issues to be able to do this safely. And then, and if things are going well, we're into the summer, late summer, we're going to take some time to think about where all the cases are being done and kind of regroup on service site, where's the best place to be doing these cases. So that's the general outline. Again, a lot of the details are going to be worked out over the next couple of days. I think that we have the ability, because of the work that's been done over the last 6 weeks, to put proper policies in place. We've been highly advantaged because we're in Los Angeles and there hasn't been a New York surge. And so we've been able to plan, and there's a sense that we can do this in a safe way. So that's what I have.
Thank you, Dr. Hines. Does anyone have questions for Dr. Hines? Thanks again. So we are
ready?
Oh, yeah.
Hi, sorry. This is Judy Turner. Thanks for letting those of us in anesthesia listen in, and thanks for all the information. It's been a very eye-opening and informative ground round. I'm just wondering, Joe, if you could speak to the hospital's approach, if possible, not just to the surgical case volume, but to other procedural areas, because you know, the coordination of all of these procedural areas, I think, is very important. And I'm just curious if you have any information on that regard.
Yes, so there's a large redesign, reset effort that's been established by the hospital, including the clinical chairs in those discussions. And for the operative and interventional areas, there's been a committee that, as I said, is meeting for the first time a little bit later this morning, that is focused on not just the operating rooms, but also interventional spaces. And that committee work will feed into the other committees that are part of the reset overall governance structure.
Any others?
So I guess I mean to say that it is going to be a coordinated effort.
Thanks again. So Dr. Naim, the chair of the UCLA COVID Research Task Force, was going to join us, but I'm not sure if he's on the line. Dr. Naim, are you on the line? Probably not. Okay. So I will reach out to him and try to have that conversation next week. I think we have concluded our grand rounds section and the morning report, and we are going to move into the M&M, the surgery M&M right now. So
this is Dr. Nick. I can give a 5-minute update. I'm so sorry I'm late to the call.
It's not a problem at all. Thank you so much for joining.
Or I could come next week, whatever works.
No, please go ahead. No, we definitely can make time for you, definitely.
Yeah, so I think the clinical research sort of activities are falling into some very important camps. One has to do around clinical trial design. And, you know, initially when the COVID-19 pandemic started, there was a concern that we would be overrun by inpatients in the hospital, and there would be a surge, and, you know, we would be sharing ventilators, et cetera. So the emphasis from clinical trial sort of protocols have been largely inpatient. And, you know, to date, there are, you know, are probably 7 inpatient protocols that are open, another 4 that are in the sort of pipeline for that. But now there's a lot on the inpatient side, and there are less inpatients than what we had been expecting to have. And so the shift has been now to outpatient types of clinical trial protocols. But, you know, the numbers of agents that are particularly interesting on the outpatient side are limited at the moment. But there has been a post-exposure prophylaxis study that just got opened, and a couple of outpatient studies that will be available to both COVID positive outpatients as well as healthcare workers. You know, you may have seen that there's a lot in the press and also from the NIH about all of these studies happening in a very disorganized fashion with few numbers of patients in a way that isn't very sort of informative. And so there's a push by the NIH as well as a collaboration on the West Coast to maybe consider developing platform adaptive studies where there are multiple arms and maybe one placebo arm that would then allow arms to be added and taken off in a way that wouldn't have each study being placebo controlled with a few number of patients. And it very well may be that in the next month, there's a movement to that. Separate from the clinical trial work, there's a fair amount of effort that's happening on convalescent plasma. We just opened that and got something in the ballpark of 800 people that have recovered from COVID with an interest in coming in and sharing their plasma as either donors or providing plasma for us to be able to track their immunity, also using that potentially for strategies around developing neutralizing antibody strategies for COVID. So there's a lot of laboratory work on the diagnostic side and the immune side, immunology side, neutralizing antibody side, to be able to try to figure out strategies that may be not available now, but maybe in the fall or winter if there's a resurgence of COVID, and newer sort of approaches would be required to be able to do that. There's a fair number of observational studies that are collecting biospecimen and clinical data as part of large academic networks, because we don't have the sample size just at UCLA alone to be able to say much compared to like New York. So the only way to really kind of participate is to aggregate our information either UC-wide or in some other sort of national academic collaboration. And then, you know, there's a lot of interesting collaborations between medicine and engineering. Some of that is around sort of the, you know, ventilator space, device space, remote monitoring space, as well as tracking, you know, and other sorts of things that might become tools that we might use later on as we're dealing with opening up, you know, certain restrictions, but needing to track kind of who gets COVID and what the modeling around that is. You know, we have a fair number of the machine learning folks that are involved with the health system to develop predictive models, et cetera. So, yeah, I think the overview largely is trials, development of kind of, you know, deep dives around serology and immunology, observational studies, collaborations in conjunction with technology and diagnostics have been largely what we've been focused on. Of course, the emotional toll that the whole pandemic has played on the public, on patients, and on providers is pretty dramatic. And so there's a lot of psychosocial sort of studies that are kicking up in the space as well. So maybe with that, I'll stop and see if people have any questions.
Thank you, Dr. Naim. Do you have any studies about the antibody testing, serology testing for UCLA health workers?
Yeah, so of course there is a healthcare worker study that Annie Ramon and Grace Alvarandi are doing. It's not serology based at the moment. But my understanding is that Sarah Dry and the pathology lab are working on a potential serology, if FDA approved serology test that would become available in early May. And that they're planning to scale to be able to do 3,000 to 6,000 of those on a day once it becomes available. So I think the intention is to have a scalable serological test that's available. And I think that strategy is important, not just for our healthcare workers, but for any external large sort of entity or corporation where they're trying to figure out how to get workers back into the workspace. Trying to define who has immunity, who has, but the false positive and false negative rates on the current tests that are available in the market has been pretty heterogeneous. And so it's been hard to really rely on anything that's currently in the marketplace there until they get validated, because the FDA has been pretty lenient in having these tests hit the market space. And so, I think it's going to take another month or so before there's a test that there's enough confidence in so that we can use it not only for healthcare workers, but in a variety of other ways to ensure that people can get back to work.
Is there a blood test to diagnose the disease? Because it sounds that the swab technique is very inaccurate when it comes to sampling.
Yeah, well, I think the people that are doing the PCR are using swabs. There's 3 different ways that people use swabs. There's deep nasopharyngeal swab. There's mid nasopharyngeal swab that patients or even a healthcare worker can do themselves. Generally, both of those are pretty more reliable than just a nasal swab. And so sometimes it's easier to just get a nasal swab, but those nasal swabs may be less accurate than doing a mid nasopharyngeal swab or a deeper nasopharyngeal swab. And there are people that are looking at things like saliva and other things, but I think that still needs to be proven whether or not those sorts of strategies are going to be accurate or not.
Any other questions for Dr. Naim? Again, thank you so much for taking the time to join our call, Dr. Naim. There are so many questions all the time, and we might reach out again in the next few weeks to have you come back and join us.
Happy to do it, and I promise to be on time next time.
Thank you so much. So we are going to move into the M&M conference now. Dr. Donahue is going to moderate. This is an internal conference for the Department of Surgery. I would kindly ask anyone that is not part of the Department of Surgery to please sign off. Hopefully we will have some joint conferences, including joint M&M in the future, but we are not prepared for that yet. Dr. Donahue, I think we are ready to start.
Sounds good. I think we have 40 minutes. We have one case with Dr. Court and 2 cases with Dr. O'Neill. So why don't we start with Dr. Court?
Sounds good. All right, is that working?
Perfect, Colin.
All right, one M&M to present from the trauma